Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Today is April 18, 2023, and I want to thank you for joining us. As always, this is your opportunity to get your public health questions answered live. We'll give you a COVID update, and I'm really pleased to have a special guest today. This is Dr. Candace Robinson. She is the medical director at CDPH over what we call our MICA Bureau, Maternal, Infant, Child, and Adolescent Health. We've known each other a very long time. Even though we worked together at CDPH, we actually worked together at CDC way back in the day. And I want to welcome you to the show. You want to just tell folks a little bit about the work that you're doing, a little bit about your background so they can start putting questions on before we turn to the update.
Absolutely. Good morning, everyone. I'm Candace Robinson. Like you said, I'm the medical director for our MICA Bureau. So I help with all the clinical and strategic things around our program for our Maternal, Infant, Child, and Adolescent Health Bureau. So I'll be telling you all about those programs today. I'm a general pediatrician by training and have been in public health for over 10 years now. So look forward to hearing your questions and answering your questions soon.
All right, perfect. So as a reminder, you can put your questions directly into the box below or use the hashtag AskDrArwady on either Facebook or Twitter. We'll start with a look at our COVID dashboard, and then we'll move into a slideshow presentation, some updates on COVID, and then Dr. Robinson will take some overview updates of the work of MICA, and then we'll use the last 20 minutes or so, or half an hour depending on time, to take all of your questions directly. So thanks again for joining us, and let's dive in. CHI.gov/COVID-. That is your one-stop shop for everything related to Chicago COVID data. And if we pull that up, you can see that the risk level here does remain low. We've got a box at the top of the page here that's highlighting a couple of things that are newer on this dashboard page. We have a dashboard related to wastewater samples, and then we also have this weekly respiratory virus surveillance report. We get a lot of questions in wondering about other respiratory diseases. So not just COVID, but what's happening with flu, what's happening with RSV, and what are we seeing for healthcare visits or hospitalizations or testing for that. And so given that many people continue to come to this page, we've linked at the bottom down here. This is where you can find the wastewater surveillance, so you can click on this and see the latest data. This is where the variants and genomic surveillance is where you can see the latest of what's happening with variants in Chicago, across the region. And then this box here, this respiratory virus surveillance, if we click on it, I'll show you. You can basically, every single week, we do an updated report. We are moving probably more toward an interactive dashboard here in time. But at the moment, you can pull up, for example, the April 14th report from this week. And it just gives you a sense of everything here in Chicago that's happening with respiratory viruses. So on COVID, our level is low. Here's our case number. Our hospitalizations are going down. Our inpatient bed occupancy is going down. Influenza is low. We've had about 200 ICU hospitalizations for influenza here in Chicago during this season since October, but no new ones this week, and less than 1% are positive. You can just read some more about influenza and then some of the other respiratory viruses. So RSV, that was that, especially with Dr. Robinson here, that was the respiratory virus that we were seeing a lot of hospitalizations and emergency department visits for in young children, and that right now is also at a very low rate. You can see less than 1%. Then down at the bottom here, some of the other viruses that we monitor. So it gives you sort of a snapshot. And then if you really want to see more details, here's exactly what's happening with influenza ICU hospitalizations, or some of the different labs. It gives you a sense of what's happening this week as compared to the season. You can look at some graphs in terms of what are we seeing week over week, what's happening with emergency departments. So we've really worked here to pull in a lot of the data that our epidemiologists look at every single day when we're detecting issues, deciding what interventions may need to be in place. And just given the increased interest in Chicago in this kind of data, did want to point you to that. So if we go back, just to the COVID dashboard page here, back up on COVID, the news does really continue to look good. We're at a low level. Just to remind you how to interpret this, we're averaging about 142 lab-confirmed COVID cases every day across Chicago. Many, many, many more than this, of course, are detected by home tests. But this gives us a sense, especially of people who are seeking medical care for COVID. If you're getting a test in a hospital or an urgent care or at your doctor's office that's going to a formal lab, that's some of what we're tracking there. In terms of hospitalizations, this is Chicagoans newly being hospitalized every day. Still about 17 Chicagoans every day right now being hospitalized with COVID. But you can see that that's very low compared to where we've been historically. You look at the beginning of 2022, we were averaging well over 200, almost 250 new hospitalizations every single day. So really much better there. We are still seeing people die from COVID, including here in Chicago. We've had a total of 8,113 COVID deaths since the outbreak began, but we're averaging less than one per day right now. We are doing more than 500 COVID vaccinations every day still, and this is low numbers of both emergency room visits and hospital beds in use. And then I just wanted to remind you that if you want to dive more into any of this, we will often get questions. Who is dying from COVID right now? Or what's happening by age? Or what's happening by race, ethnicity? What's happening in my zip code? These buttons across the top are what let you explore that yourself. So if, for example, we just go to cases here, this is where you can dive in and really see what's happening. So on this date range, if I'm not interested in the entire since March 1 of 2020 until April 13, if it's just like, okay, what's been happening, if I move this up to, let's say, I don't know, like one of these here, like sure, December 28th. So in about the last 4 months or so, what has that looked like? It'll give you a sense here what's happening with cases, hospitalizations, and deaths. But if it's like age, for example, if I click on age down here, I can look at all of this by age. And this will give me the average number, and this will give me the cumulative total for that time period. So for example, in this time period from December 28 to April 12, just in Chicago residents, we've seen 105 COVID deaths. But among those, 54 down here at the bottom in gray have been in Chicagoans over the age of 80. 54 of the 105 deaths. Another 22 in people in their 70s, then 15 in people in their 60s, 12 in people in their 50s, and 2 in people in their 30s. And so again, this looks, we've always seen an age predominance, but it's especially strong now. And especially if you compare, we've seen the lowest number of COVID cases during that time in people over 80. See this? We've had about 1,778 people over 80 formally diagnosed in a lab, meaning they're getting medical care, and yet 54 deaths. Whereas we have the highest detection of cases in children. A lot of kids are getting tested in Chicago public schools still, or going in to get pediatrics. But even though we are detecting a lot of cases, the number of hospitalizations for children is the lowest of any group, and then the deaths are at 0. So you can explore this lots of ways. You can look at case rates by age. You can look at hospitalizations. You can look at deaths. You can do this by gender, race, ethnicity. There's lots of ways to explore. But I just wanted to remind you that we continue to update all of this data every week. And so if you want to explore something about, your neighborhood, you can go to cases by zip. We continue to really update this. You can look at weekly totals. If you want to understand what's happening with testing patterns, again, laboratory testing patterns, vaccines, age, gender, race, ethnicity, vaccines by zip code, all of this is still here and it is not going away. Even with the ending of the public health emergency in May, we are committed to maintaining this level of surveillance and information for the public. So I went in a little more detail than I sometimes do, but we continue to get questions. We also are updating the vaccine coverage down here at the bottom if you want to see what's happening with boosters by race, ethnicity, or age. Vaccine effectiveness, that's looking at breakthrough infections, hospitalizations, really showing how important it continues to be vaccinated and to stay up to date with your vaccines continues to be the most important thing in terms of especially preventing those severe illnesses. So this is Chicago data on that, social impact. And then the data portal is where you can download all this data if you want to explore it yourself. And then the Chicago Health Atlas, this is our link to all of the other CDPH data. So outside of COVID and infectious diseases, this is where you should go to explore more. Okay, we're going to go ahead and turn to just a quick overview. So again, Candace Robinson, if you joined late, is my guest, the medical director of our Maternal, Infant, Child, and Adolescent Health Bureau. Very briefly on COVID, we're doing really well across the country right now. A reminder that the orange counties are at that high COVID community level, meaning a high level of hospitalizations or occupied hospital beds per population of the county. And only 0.5% of U.S. counties, none in Illinois, are at that high COVID level this last week. And just 2.4% are at the medium level. There are a few counties there up in northwest Illinois that are at a medium level, seeing some more hospitalizations. But overall, the news is really very good. And here in Chicago and in Cook County, our risk is low. This is the data that underlies this. So our case counts, we want to see those well below 200 per 100,000 population over the 7 days. And, you know, we're well under that. 38 and 41 is very far under that threshold. New admissions, we want to see that under 10. Again, per population in the 7 days, and we're at 4 and 5. Those are very good. And then our percent of staffed inpatient beds, we want to see that at less than 10%, and we're at 1.9% and 2.1%. So low and staying low, and that is what I want to continue to see. We've also been getting questions about variants. Reminder that you can get all of this also on our dashboard whenever you want to take a look. But as a reminder, everything that we are still seeing across the whole U.S., Region 5, which is the Midwest, and Chicago, is all still Omicron. So yes, there has been some increase in various subvariants within Omicron. So XBB 1.5, that's those big purple bars. Those are that's the one we've had the eye on most strongly because it's the one that was out competing over these last few months. The one just below that, the XBB 1.16, is growing right now. It's about 6% of cases in the Midwest, but we are not seeing signs at this point of more serious outcomes or clinical presentations. We've been watching that subvariant actually in India for a number of months. And so broadly speaking, the news remains good in the variant land. As long as everything is still Omicron, that means that our vaccines that were updated this last fall, that were updated to help protect against Omicron, should continue to perform well. And broadly speaking, we know that that COVID is going to continue to mutate, and we're still seeing that. But no signs at this point of any huge new emergence of a very immune evasive or different clinical presentation. So that's good. And across the U.S., we're really seeing similar patterns. I also wanted to announce, this is breaking news just about an hour ago from the FDA. So the FDA announced that bivalent mRNA vaccines, so the mRNA vaccines are your Pfizer vaccines and your Moderna vaccines, they are now the only game in town. So to remind you what that means, the original vaccines that were made against COVID by both Pfizer and Moderna were just made kind of against the original variant, the original strains of COVID. And then we had an updated, what's called a bivalent vaccine that came out this last Labor Day. So in the fall, there was an updated vaccine that both boosted your protection against the original strain of COVID, but then also added protection against Omicron, specifically BA.4/5. And so the FDA has decided that we are now only going to use bivalent Pfizer or Moderna boosters. So what that means, if you got your updated bivalent Pfizer or Moderna booster after Labor Day, you are still up to date. You don't need to do anything about it. But if you are someone who never got your original COVID vaccines, for example, or are looking to get, never got that original booster that was recommended, haven't come up to date since Labor Day, the vaccines that will now be given for Moderna and Pfizer are those bivalent vaccines. And this is relevant, actually. I saw a patient in clinic last Saturday. I see primary care patients, and I was talking to a patient who had come relatively recently from Mexico, had never had a COVID vaccine of any kind, and we had a conversation about it and said, yep, I'm willing to get vaccinated. With this change, I can now start her original vaccination with that bivalent vaccine, which really I think is the best vaccine in terms of the best level of protection. So it simplifies for providers, simplifies for patients, all ages, 6 months and up, we will be using for Pfizer and Moderna these bivalent vaccines going forward. So that was good news to hear. The monovalent, meaning those old vaccines, are no longer authorized for use. So how are we doing with vaccine, and especially that booster coverage? So that booster, that's the same one I'm talking about, the bivalent vaccine that became available last Labor Day. So over 602,000, we've now crossed that 600,000 mark, have been administered to Chicagoans since authorization. It is ticking up 500 or so every single day in terms of people coming up to date, which is good to see. We are ahead of the U.S. in terms of people who have had that updated bivalent booster dose, but I'll be honest with you, it is nothing to brag about. Just a quarter of the population over 18 even in Chicago has had that bivalent booster, and people who haven't had it don't have the best level of protection against Omicron. The thing I am the most worried about still is the bottom of this slide. The population over 65 here in Chicago, only 41.8% of Chicagoans over 65 are up to date with their COVID vaccines, meaning they had an updated COVID booster after Labor Day. And I already showed you in the data right up front that it is people in their 60s, 70s, and 80 plus who are by far the most likely to be hospitalized, by far the most likely to die, and it is therefore the most critical that that age group get their vaccines. And it is the one place where we are actually now lagging behind the overall U.S. population. So I've talked a lot before. We're doing a lot of outreach there, doing a lot of work with senior groups and senior centers, our long-term care facilities, et cetera. But if you know somebody who is older, who isn't up to date, it is not too late to get that booster, and in fact is critically important for those who are older. I also, just a quick comment on some of our vaccine numbers, if you haven't looked. When we look at our initial vaccine coverage, where, for example, this woman I saw in clinic yesterday who recently came from Mexico, is a Latina, and is just now getting vaccinated for COVID for the first time, we are seeing, especially Latinx Chicagoans, continuing to sort of get those first vaccines, like people who had never previously had a vaccine. It's been increasing, and of course it's increasing across all race ethnicities, but we've been really pleased to see that, especially in Latinx Chicagoans. So if you look across all of Chicago, folks who have had at least one COVID vaccine, it's almost 90% of folks who report Asian non-Latinx background. It's about 81% now of those who report Latinx ethnicity. It's about 78% of those who report white non-Latinx ethnicity, and it's about 64% of those who report Black non-Latinx ethnicity. So still quite a bit of disparity there. There's been a lot of work, especially with Black and Latinx communities, in terms of making sure vaccines are available. I should note that we know that there is some data that's not included here. People who got vaccinated at the VA, people who got vaccinated in other states, Indiana, et cetera, would not be showing up here. But by and large, we know that this remains a concern. And so especially in parts of Chicago that are predominantly Black non-Latinx, vaccination remains a major point of focus. And I want to just remind folks that now the vaccine for folks who haven't had any of their COVID vaccines will be that bivalent, meaning the one that we've had a lot of research in, a lot of experience in, a lot of safety data in, and is right away you can get that protection, not just against the original COVID strain, but against Omicron. So I think that's good news. Similarly, if we look at people who completed their original vaccine series, we've seen nice improvements there in Latinx Chicagoans too, more likely than white Chicagoans to be vaccinated. But when we look at bivalent booster uptake, that is less true. And I remain concerned here that in Latinx Chicagoans in particular, less than 20% for both Latinx and Black non-Latinx have had that vaccine, as compared to about 30% of white non-Latinx. None of these numbers are particularly good, but I do remain the most concerned about Latinx and Black non-Latinx communities. Less protected, more possibility for emergence of further resistance, further transmission, et cetera. So just a quick reminder, nothing's changed here. If you test positive for COVID-19, days 1 through 5, you should be staying home. If you're at high risk for severe illness, people who are over 50, people with underlying conditions, you should be talking to your doctor about getting early treatment, or your pharmacist, or give the health department a call, because we now have not just vaccine, but safe early treatments that can help keep people who are at higher risk out of the hospital. And then day 6 or later, if you're feeling better, you can end isolation, but you do need to wear a mask days 6 through 10. None of that is changing, and I don't anticipate that changing anytime soon. Another just quick reminder that our belt and suspenders, the belt is getting vaccinated and staying up to date, but our suspenders are these early medications. Paxlovid is the most well known. So if you're at high risk for severe illness and you test positive, regardless of whether you are vaccinated or not, you should be evaluated, and in most cases, be treated with early treatment. So Paxlovid is the oral antiviral therapy. You take it for a few days, but you've got to take it in the first few days of illness. It doesn't work because it stops the virus from copying in your body. So you can't say, I'm going to wait and see for a week or two, and if I'm not doing better, maybe I'll take the med. This is a med that you have to take early to stop it from replicating in your body, and therefore making it more likely you'll see that more of that organ damage and kind of full body. We want to keep COVID as an upper respiratory cold type symptom, as opposed to it turning into something that's more deeply affecting people's lungs or their other organs. And the combination of vaccine and treatment is what can help us do that. And then just a reminder, CDPH is still operating our Protect Chicago at-home program. Anybody in the whole city of Chicago who wants to get updated, anybody over the age of 6 months, we will come to your home free of charge. We are still operating now Saturdays and Sundays, 8 a.m. to 6:30 p.m. We've been adjusting that time based on demand, and we'll bring up to 10 people up to date. So whether that's for COVID, whether that's for flu, use this opportunity. If it's your first ever COVID vaccine, we love it. If it's your booster and you just haven't gotten around to it, we love that too. So give us a call. I wanted to also just mention, and we've been talking about this pretty much every week on Facebook, but as the public health emergency is ending, families are going to have to re-enroll in Medicaid and Medicaid equivalents. During the emergency, all families across the U.S. were automatically re-enrolled without needing to resubmit paperwork. And so really, as of March 31st, that continuous enrollment condition ended, meaning that states now need to re-enroll anybody who is eligible for Medicaid. So starting in May, next month, the state of Illinois will be mailing out these renewal forms. They don't all come at the same time. So if you are not due for redetermination until later, that's okay. But my point is that anybody who is enrolled in any of the Medicaid plans, you want to watch your mail this time of year. You want to make sure you don't miss this re-enrollment. And you want to make sure, therefore, your contact information in the state's database is up to date so you can get your renewal form. And so you can go to abe.illinois.gov to read more about that. You can click and log in. There's also a phone number, 877-805-5312, that you can call on weekdays to make sure your address is right. That's really the most important thing right now. Make sure your address is right so you get the information. And then when it's time, you need to turn in the forms to see if you're still eligible. And just a quick reminder for any Chicago Public Schools families, do reach out to the Healthy CPS hotline at 773-553-KIDS, or there's information there. But that's what you need to do right now. And just a reminder to everybody that we now have a single number in Chicago and suburban Cook, 211, that you can call if you have questions about human services, about health services. It's an important new resource. Most of the country has had it for years. We're really excited that it's now here in Chicago. You can also go to 211metrochicago.org if you have questions. And always, we continue to operate the COVID hotline at CDPH, 312-746-4835, 7 days a week. With that, I'm going to hand it to Dr. Robinson to do an overview of our MICA Bureau, and then we'll turn to your questions.
Great. Thanks, Dr. Arwitty. So a little bit about our MICA Bureau, Maternal, Infant, Child, and Adolescent Health Bureau. Really, the MICA Bureau consists of 5 bodies of work, I would say, and I'll talk about each of these bodies of work, but really it's our WIC and nutrition programming, our Family Connects nurse home visiting, our school-based health programming, our lead and healthy homes programming, and our reproductive health programming. Let's talk a little bit about each of these and what they do. So first of all, our WIC program is our Women, Infant, and Children's Supplemental Nutrition Program. Our WIC program serves pregnant, postpartum, and breastfeeding people, infants and children up to 5 years old, by providing access to healthy foods, nutrition education, breastfeeding support, health screenings, and referrals to additional services. Now, CDPH is actually the largest supplier of WIC here in the Chicago area. We run six clinics, and we have 8 delegate agencies who also run clinics. And so we actually provide direct services through CDPH for WIC. But what WIC does, and it's really important, there's lots of research around WIC and how important it is. And research has shown it reduces the risk of prematurity and low birth weight in infants, reduces the risk of infant death, reduces obesity, child neglect, and food insecurity for families. And so I have a website at the end of this slide about all of our programs, and I'll show you this website. But we want to make sure that everybody who thinks they may be eligible for WIC goes to this website to see if you're eligible for WIC, because it's such an important program for families here who are eligible here in Chicago.
And we hear a lot about food insecurity, and this is one of the most important programs for children, and then especially for people around pregnancy, but especially for kids, young kids, especially before they're in school. This program is really critical, and we want to make sure everybody who is eligible for it is enrolled.
Absolutely. And I think, as other benefits other benefits increased around COVID time, and as those benefits go back to pre-COVID levels, WIC can be an important program to kind of help families who need the support and fill in those gaps that will be left behind by those other programs. Our next program that I'll talk about is Family Connect Chicago. Now, Family Connect Chicago is another program we have here, and it's a program that was actually launched here in Chicago right in 2020, right just before the pandemic began. What is Family Connect Chicago? Family Connect Chicago is a universal home visiting programs for postpartum people and their families. And so who is it for? It's for all families who deliver at a participating hospital. Now, Family Connect started off in 4 hospitals, but it's in the process of growth. So we're now in 5 hospitals across the city, and looking to be in 8 by this summer, and hopefully in all 15 birthing hospitals by next year. And importantly, this program is operated at no cost to the recipients of the program. So how does it work? What happens? A nurse connects with the family with a home visit, usually around 3 weeks after the infant is born, comes in, does a full check of the birthing person, of the infant, assesses for family needs, be that resources or education needs. This is a very vulnerable time in a family's life, and we recognize that everybody needs support around this time with a newborn. And then that nurse kind of connects that family to community resources or provides educational resources for that family. And that just allows that family to connect with their infant and focus on their connections with their infant. So that's part of the main parts of Family Connects. Now, that's the part that's visible. Family Connects is supported by a lot of additional work. We have the home visiting that I just talked about, but there's also a community alignment piece where we've divided the city into regions and really work closely with community-based organizations and agencies who work in those regions, and community members in those regions to kind of identify the resources that are available, very local in the regions, identify gaps in resources, and try to address those gaps in resources as well. And then, of course, at CDPH, we have a big focus on data and monitoring. So we're constantly kind of following the data that comes out of this program to see what outcomes we're seeing, and to see what we can do to improve the program. So that's kind of Family Connects in a nutshell. I will note also, you may see coming soon a lot more information about Family Connects. As Family Connects expands, we'll be entering into some more marketing around it, so look for information about Family Connects soon. Another program that's under our MICA Bureau is our Office of School-Based Health. Now, this program has a couple of different arms to it. We have our school-based vision program, which we run through the Chicago public school systems, where we have comprehensive eye exam and free eyeglasses for kids grades K through 12. We have our school-based dental program, also run in conjunction with Chicago Public Schools, where we do dental exams, educations, fluoride, cleanings, dental sealants, also in grades K through 12.
Actually at school, right?
Actually at schools. We have providers who actually go into schools and provide these services for the kids. And then, you know, sometimes in those schools we find kids who need additional care beyond what can be provided in the school. And so those providers then connect those kids with providers in their community who can follow up and provide that additional care. We also have our adolescent sexual health program. So we have a district-wide condom access and educational resource program. And then we have our Chicago Healthy Teens and Adolescents program, which we call our CHAT program, which provides sexual health education and optional confidential free testing for gonorrhea and chlamydia as well. And then we also have kind of this new expansion of our Office of School Health that's really working to create stronger operational and clinical support for our existing programs, but also to strengthen our interdepartmental collaboration and programming with schools throughout Chicago, and really to build consistent messaging and pathways of communications between the Department of Health and schools across Chicago. I think one thing that, you know, COVID highlighted is that there's a need for us as the health department and for schools to be in constant communication around a host of different things, not just COVID. And so we continue to try to strengthen those relationships between schools and the Department of Public Health through this office.
Right, and just to be explicit about that, you know, Chicago Public Schools, as the largest public school system, is often our primary partner in this, but we regularly also work with private schools, and schools of all different levels, right? From sort of the pre-K and the preschool, the higher ed, you know, there's a lot of sort of school health work that goes even beyond CPS.
Absolutely, early childhood, all the way through higher ed. Next, we have our lead poisoning prevention and healthy homes programming. Our lead poisoning prevention and healthy homes program really works to detect and address exposures to lead hazards and is really leading efforts to permanently eliminate lead exposure to children. How do we do that? We do that in a few ways. First of all, interesting fact that I think everybody might not be aware of is that all children in Chicago, all children who live in Chicago, should be tested for lead at 1, 2, and 3 years of age. And so what happens? When a child is tested for lead, those results go to the state, and then the state shares those results for Chicago children with CDPH. If a child has a level of lead in their blood that is 5 or higher, that is the action at the level at which the Department of Public Health takes action. And we provide nurse case management, where the nurse kind of connects with the family, provides education, does some assessments, and provides connection to resources. We do environmental inspections, where we go to the home and see if we can identify a source of lead, or if it's not, we can't find it in the home, where else does the child spend time to find that source of lead for that child. We have our Healthy Homes Grant Program, where we provide financial assistance for qualifying families to help to make the repairs to their homes, both to lead and other home hazards. And then we also engage in a lot of community engagement with community-based organizations, with providers for provide education, as well with public campaigns. You may see billboards. We have billboards right now going on around lead and lead testing. I saw one on my way into work just the other day. And so that's where that community engagement comes in. So what has this resulted in? And I think this is a story of success, but let me be clear, the work's not done. But I wanted to show this graph. This graph is in our recent lead report that we recently published. And this shows the prevalence of blood lead levels that were at that level of 5 or higher. Now remember, I said that level of 5 is the level at which we now, as a health department, take action. We say that's the level at which we need to intervene. Well, back in the mid-1990s, about 70% of children between 0 and 5 years of age had a blood lead level at that level, a little over 70%. But if you look at this graph, now in 2021, which is our latest data that we have published, we're less than 2% have a level there. So I think that's a great testament to the work that the health department has been doing through the years with case management, with going in and repairing homes, identifying where the lead is, making those repairs, but the work isn't done. You know, we're going to keep going. We want that number to be 0%, but I think it's a great success.
And just for a little context for folks, if you go back in time, these numbers would actually be even higher. Like there's been 50 years of work by public health to really work on getting rid of the environmental issues that impact lead. And so you think about going back to when we took lead out of gasoline. You go back and finally when lead came out of lead-based paint. You can't buy lead-based paint to paint your home anymore, thank goodness. Most of when our inspectors are in homes today, most of the time, the huge majority of the time, we are identifying older lead-based paint that maybe is not in good repair and is peeling. That is right now the main source of lead. But it really is this remarkable sort of behind-the-scenes story of just chipping away year after year after year after year. And as we make progress, the level where we intervene has actually dropped. So, if you go back to the 90s there, where 70% of the kids had a level of 5, at that point, probably the level where we were intervening was more like 10 or more like 15 or more like 20. Like that level has dropped because as it has been less common for children to have these much higher levels of lead as we've made progress, we want to get to the point where we can continue to drop the level where we intervene. And actually there's conversations about dropping that even further. Every time we drop it, it means there's additional resources needed by the health department. But I thank you for bringing this because I think it's an example of where public health has made so much progress, but often pretty behind the scenes. And we're not done. And there's still too many children in Chicago who are lead poisoned, but it is remarkable progress.
Absolutely, absolutely. And then our fifth body of work, and I would say this is kind of our more budding, standing up body of work, is our reproductive health strategy. And this is really around ensuring all Chicagoans and those who come to Chicago to seek care have access to comprehensive reproductive and sexual health care. And around this, we're really kind of doing this on multiple fronts through public education, through policy, through external provider support, and through internal professional development. So this is a body of work that is growing, that is evolving, and that is more to come over time, but it is certainly a very active body of work and lots of resources on our website about where to find care, lots of resources on where to find different types of reproductive care on our Chicago websites.
Yeah, and just explicitly, there is, of course, much more interest in safe abortion access, and so that is very much part of this work. There is information on the website, but we try to take a larger reproductive health strategy there. We believe firmly that people should have access to all reproductive health resources up to and including abortion care if that is necessary, but it is a larger problem and one that we're trying to think about comprehensively.
Absolutely. And then other things you may see from the MICA Bureau. We often do campaigns around different topics. You may have seen around town, we recently did a safe sleep campaign in conjunction with a lot of other agencies around the state under the title of Illinois Safe Sleep Support, because safe sleep is so important, and sudden unexpected infant death remains such a cause of infant mortality here in Chicago and Cook County. So you may see billboards not just about lead, but around safe sleep. Special websites are dedicated to safe sleep as well. And then also we recently, I think last year now, relaunched our new website, oneshyfam.org. Now this website has all of the information about all of the programs I talked about today, all resources related to maternal, infant, child, and adolescent health here in Chicago, family support resources, reproductive and sexual health resources. There's a lot of newborn care resources for those interested in the topic, care for birthing persons after birth resources, etc. And all information about the programs that I talked about are also on this website. So we encourage anybody, any families, this is a website for all Chicago families, anybody to check out our website, oneshyfam.org, for additional information on MICA and on our activities and resources.
All right, great. So we will go ahead and transition into your questions. And if you join late, this is Dr. Candace Robinson, the Medical Director for our Maternal, Infant, Child, and Adolescent Health Bureau. Thank you. There is always so much in this bureau. I know about it, but then the opportunity to really see that breadth and ask questions, I really appreciate you being on and the work that your whole team is doing in this space. Let's see, I'm just looking through the questions. We've got a number of questions. Okay, here's a good one. Maria is asking, what hospitals is Family Connects in, and is the program available to all families regardless of insurance status?
Absolutely. So the program is currently operating in 5 Chicago hospitals: Rush Medical Center, Humboldt Park Health, Mount Sinai, University Chicago, and Swedish. And it is available to anybody who delivers in those hospitals regardless of your insurance status, regardless of income. It is any person who, now the one caveat is you have to be a Chicago resident. So it is only available to Chicago residents, but if you're a Chicago resident who gives birth in one of those hospitals, then you are eligible to participate in Family Connects.
Perfect. And we really, as you said, we want to get to a point where every baby born in the city of Chicago, this is a routine part of care. Why is the visit about 3 weeks after? It's a good question, and it's one I used to have too.
Yeah, the 3-week mark is a good mark. So traditionally for care here in the United States, we have the mom and baby go home from the hospital, and then the baby is normally seen pretty soon after birth, but mom traditionally wasn't seen until about 6 weeks after birth. And so that's a while for it to be at home, for mom to not be seen sometimes. And sometimes there are questions, there are baby medical things that occur or issues that pop up. So this visit at the 3-week mark is really a critical period. It allows the nurse to really get in there to see mom, to be able to identify any possible medical issues that it may have arisen, both for mom and for baby. And to also provide any education, any resources. We know families, when you go home, everybody's rearing to help in those first couple of weeks. Everybody's right there when you first go home. But about 3 weeks, some of that help has started, people have started to go back home, and some of that help has started to go away, and maybe you have additional questions. So it's really a critical time period for families with a newborn.
Yeah, and I'll just add, mental health stressors can be really pretty significant at this time. We often see young families not getting as much sleep as they might have, and just, it's a major time. And for me, one of the pieces of data when we were deciding about this and sort of how big to take it was that we saw in surveys here, it was over 90%, I want to say 92 or 93% of Chicago families, all Chicago families, had some kind of unmet need sort of at this time period. And for some families, it might be, nutritional or diapers or, material things. For some, it's mental health or more physical health resources. We're really focused on infant mortality, maternal mortality. What can we do to work on that? And there's certainly a lot of focus and needs to continue to be focused in the prenatal space. But this time right after birth is also a really vulnerable time. So there's lots of other questions, so we'll hold it at that. But thanks. We'll go back and forth between some ones that are kind of a little more COVID or for me, and some ones that are for you. Okay. So. Karen Nathan Sussman on Facebook says, I understand, or I've heard, that second bivalent boosters could be authorized in the U.S. this spring for certain populations that are immunocompromised or above age 65. Can you share your recommendations and guidance? Who should get a second bivalent booster? And thank you for your extraordinary guidance. So Karen, excellent question. I've been answering this question and looking at all the data and talking to everybody about this. At this point, there is not yet a recommendation for a second bivalent booster. So if you are up to date with your vaccines, meaning you had your bivalent booster after Labor Day of last year, you do not at the population level need to get another bivalent booster. The big question I think on this, frankly, is what is happening with the variants. If we had seen the emergence of another variant that's significantly different, or in some way thinking that the vaccine may be less protective, that is a piece of information that that could have changed that recommendation. I never want to say never, so it could still come out that there is a decision to do a second bivalent booster, but at this point, you are up to date. There is not a recommendation for a second bivalent booster. There's a very small number of people who would be seeing specialists for their immune problems, who we know maybe they're on medications that significantly depress their immune system. They're getting treated for cancer. They have immune deficiencies. There's a small number of people in the US or in Chicago who may not actually respond well to vaccines. They don't have negative side effects, but they don't get the level of protection. And so there's always been sometimes some slightly different recommendations around prevention and treatment for that group. But for the general population, no matter your age, there is not at this point a recommendation for a second booster. I fully anticipate that as this fall, we will be most likely doing another round of sort of an annual vaccine update like we do for flu. I think the question is, in these months before that, does something change significantly enough in COVID that we make that recommendation? But my guess with how COVID is going right now is that realistically, for most people, and I think most experts are feeling like this, that it probably will be until fall. So stay tuned. We will absolutely let you know if there is a recommendation for another booster, but otherwise, if you've had that, you've had the most important thing to protect yourself against Omicron. And then there's a related one to that, and then we'll get another one for you. Amanda DW on Facebook is saying, hi, Dr. Arwady. For those under 5, if you weren't eligible for the bivalent yet, should you just get it next fall? Yeah, good question, Amanda. So this also gets into that for some of those very youngest kids, it can sometimes be harder to find the bivalent vaccine. Like there is more monovalent vaccine out there for those youngest kids. There's plenty of bivalent for older kids and for adults. But I think broadly, if you're not eligible yet, if you're talking about Pfizer, probably you had your original 3, you're up to date. You do not need to get another booster dose for that group. That group 2, I would be expecting that you would, for everybody, for the whole family, likely be doing a booster dose next fall, to be determined for sure. So just because it has changed that bivalents are the only thing that are approved, you are still considered up to date, including for the youngest kids, if you've had your sequence to date. And if there is any updates or any changes on that, sometimes behind the scenes there can be small things changing. Reach out to your pediatrician if you have additional questions. And we also keep our website up to date with all of the latest about kids and vaccines. Okay, for you. All right. From Jen here, how do you find out if a child has a blood level above 5? Should families be bringing children to the health department to get tested? Just maybe a little more about some of that data and how we understand it.
Sure. So these tests should be happening at age 1, 2, and 3 years of age as part of the well child check with your child's provider. So we at the health department don't routinely provide lead testing. So if you have not had your child tested for lead at these ages, or you're unsure, talk to your child's provider about whether they've had a lead test at that 1, 2, or 3 years of age.
And this means like their regular pediatrician's office, their regular family practice office, wherever you're getting that care. One of the reasons you don't want to miss your well child checks at 1, 2, and 3 is that, among other things, that office should be checking for lead.
Yes, and so when that office checks for lead, all offices are required to report that level to the state, no matter what.
And it happens electronically, so it comes automatically.
Automatically to the state. And then what happens is the state says, oh, this child lives in Chicago. And so they pass that data on to us at the Chicago Department of Public Health. And so that's how we find out about a child who has a lead level of 5 or greater. So as Dr. Arwady mentioned, when you're going to see your regular child's provider, their pediatrician, their family practice specialists, et cetera, at those ages 1, 2, and 3, make sure that you're asking about lead testing at those ages. And that's how we will find out about those lead levels.
All right, perfect. I think I'll take one. We'll keep going back and forth here. Jill Dispensa on Facebook has a mental health question. She says, can you share how many people used CDPH mental health clinics that were closed before they were closed as compared to how many people are using community clinics funded by CDPH now? Okay, so not everybody knows sort of the details kind of that are within your question, Jill. So let me just highlight a little bit very high level here. So it would take me about 15 minutes to kind of give you the whole history of mental health clinics in Chicago going back to the 60s. But most recently, when people are talking about mental health clinics, they're often talking about CDPH we used to have 12 clinics, and then I don't know, more than a decade ago, when state funding was cut, we actually closed half of those clinics because the funding wasn't available for them anymore. And there's been a lot, understandably, there's been, I think, a lot of concern and conversation about, what happened there, and did that leave a big gap? What I want everybody to understand is that we are committed to public health mental health clinics. Like, of course we are. We operate 5 mental health clinics today. We've done a lot to build up those hours and that capacity. But CDPH mental health clinics, though, even if they are operating at sort of full capacity, they are typically seeing hundreds of patients. They are not seeing thousands of patients. And some of this is because people are getting care, you're coming back multiple times to see a therapist. It's not like it's hundreds of visits, but in terms of individuals served. And so just to kind of give you a sense, in 2019, which is when I came in as acting commissioner, and we did a full look at everything in mental health, City of Chicago taxpayer dollars were being used to support the mental health care for approximately 3,600 Chicagoans. And that included people seen at our 5 clinics. So, if you do that math, that would be, let's say, on average, it's less than about 700 people per clinic. But in fact, also that included people who were being seen through some other programs and other agencies at higher risk. And so we were serving about 3,600 Chicagoans. Critical work, excellent work. But 3,600 people in the scale of a city of nearly 3 million people and all of the folks who need to access mental health, that's where the gap is. And so the challenge is, let's say we started another 6 clinics again, doubled our number of clinics. You would then extrapolate, you'd go from serving maybe 3,600 people to, once everybody was hired and once everything was built up, maybe you'd serve 7,000 people or 8,000 people. Great and important, but again, nowhere near the scale. And so what we've really been trying to do is both double down on, the direct clinical piece where there are gaps, where we need to fill, but even more, we've been funding clinicians, mental health clinicians, whether that's psychiatrists, whether that's therapists, folks focused on children, but to provide outpatient mental health care in existing locations all over the city. And so as opposed to standing up a whole new clinic, you say to a federally qualified health center who is providing really important no barrier primary health care and probably some behavioral health, mental health care, but probably has not had as much resources and ability to do longer term follow-ups. We are funding the placement of clinicians, sort of like a grant, but with personnel to those clinics. We've given funding to place personnel in the community mental health centers that are funded by the state. We've paid to put clinicians in some newer places like food pantries, or most recently libraries, places where people are coming with mental health needs already. And the best practice is really not to have kind of a standalone mental health clinic, but as much as possible to integrate mental health into services that other people are receiving. And so with that, we went from serving about 3,600 people in 2019 across the 5 clinics that we directly operate, as well as some of other programs, all the way up last year to around 74,000. So from like 3,000 to 74,000. Huge increase. There's still way more to go, but that is really the scale that we're talking about. And so when I look back at the numbers that we were serving, it's in the thousands. It's not in the 10,000s. It's definitely not in the hundreds of thousands. And we really, when I think about no barrier mental health care that you can get regardless of your immigration status, regardless of your insurance status, et cetera, I want us to be thinking in the tens of thousands or ideally the hundreds of thousands range. Those are the numbers we think about for all of the other public health things that we do. So I hope that puts it into some context. And just, one other note, because this has come out, when I say we close the clinics, like, we meaning the city. Like, I didn't even live in the city of Chicago when this was happening, and I've been reading a lot of strange things about myself where people say, I was involved in closing these clinics. Like, definitely I was not. I do understand, I've looked back to understand the finances of why that happened. But during the time that I've been the commissioner, all we have done is grow mental health, and that, of course, is my goal. Okay. For you. Colleen, this is a good question. If my child gets tested for a blood lead level below 5, but not 0, what should I do? Does it need to be above 5 for the health department to respond? I think that's a really good question.
Yes, so right now the health department's level of action is 5. Typically what happens is if you're, depends upon how old your child is, but if you're less than 5 but above 0 and your child is 1 or 2, then your pediatrician will continue to test according to those guidelines at 2 and 3 and go from there. So you will be followed still according to the guidelines and being tested at 1, 2, and 3 years of age. But the health department really steps in and does their action starting at a level of 5 or greater.
And just for some context, if we look at the data from an epidemiologic standpoint, I was born in the 70s. My blood level as a child was certainly greater than 10, just so you know that. And I think we really have made major progress here. And so I want to put it in some context. Ideally we are seeing no blood lead levels, but a level of 2 or 3 or even 5 is not an emergency. At 5, we want to really intervene. The goal is to not see it go up further. But I want to just put those numbers in some context for people. The health department, if you look back, 50 years ago, we were responding at levels of 50 and 60 and 70. Once you start getting into double digits of numbers, we are paying more attention. Once you're starting to get over 20, it's like, ooh, there's something really more significant. A child would be hospitalized for treatment, usually around 40, just to put it in some perspective for you, because I think those numbers can be hard for people to hear. So when I'm seeing a level of, my nieces or nephews might have a level of 2 or 3 or 6, or it's at a level that I want to pay attention to it if it's elevated, but it is not a level that is an emergency. And I think Chicago just has a lot of older housing stock generally. And so we also have available on the website, there's information about if you're going to be doing contracting in your own home and scraping and you want to hire a lead safe contractor who knows what they're doing. You really, especially if you have young children at home, it's not the best idea to just start kind of scraping off old paint because chances are very good that there's lead-based paint there. So we operate some education workshops for people who want to do those repairs, or that's the kind of question you'd want to ask, someone who is doing home repairs.
Yeah, absolutely. And I would say, 1978, that's the year that lead was taken out of paint. Right. And so if you have a house that was built before 1978, odds are there's probably some lead-based paint still somewhere on that premises. So if you are doing some renovating, et cetera, you really want to make sure that your contractor knows about lead and has some lead-based experience as a licensed lead contractor so that they can assess whether or not you have lead paint and then treat it appropriately.
That's right. And generally, when you have, my home is much older than 1978, when your paint is sort of in good repair, it's not a major problem. But where the problems start to come is when it's peeling, you start to see some disrepair, internal, external. And that also tends to be the point at which sometimes people will say, oh, I want to take care of this, and sometimes don't realize that there's certain things you want to do, especially if you have young children at home, if you are working to do those kinds of renovations. All right, good questions, folks. We are just about at time, so I'm just going to take a couple more here to end it out. Delaney's asking, when the public health emergency ends, will CDPH stop tracking COVID cases? Will all reporting nationally end? Says, I'm glad we're not where we were in 2020 in terms of cases, hospital deaths, you and me both, but I'd still be interested in seeing what COVID looks like in Chicago, even if the, quote, emergency has ended. Yes, so CDPH will absolutely not stop tracking COVID. I think nationally, we are going to see some changes. As the emergency ends, there have been some requirements on laboratories, for example, where they've had to report not just positive COVID tests, but negative COVID tests. And if you don't have the negative COVID tests, you can't calculate things like percent positivity. It's one of the reasons we moved away away from percent positivity a long time ago in terms of it being a primary indicator. But there are also certain reporting of COVID data nationally and in some other states that is tied to the emergency. And so it will probably be harder for the CDC to have as much of a national picture. That's a whole other story. So I expect that we will see changes in that national landscape in terms of data. I think it's possible that we may see at the national level a move away even from those community levels, the low, the medium, and the high that we've come to know over the last year and a half. I don't know for sure that that is what is going to happen, but I want to reassure you that here in Chicago, my epidemiology team, all my response teams are very much still on COVID. We still have COVID funding, at least for the next couple of years, that lets us maintain and actually grow a lot of the intelligence units, whether that's the wastewater surveillance, whether that's making sure that we're appropriately collecting samples across the city and doing that genomic lab work, looking for variants, making sure we understand what's happening with COVID, the various response actions around vaccine, et cetera. So I do not think our dashboard is likely to change probably much at all as the public health emergency ends. But we are paying a lot of attention to some of those changes nationally. I am right with you. I like to see data. I make decisions based on data, and we don't need to count every case. We've never needed to count every case to understand what is happening with COVID. It's the same thing with flu. I don't have to count every case of flu, but we want to understand the patterns, and there's ways that you can sample to understand that. There's ways that you can look at things like hospitalizations and deaths. And I want people to have some understanding of what different diseases are doing. And so one of the reasons I showed you that respiratory virus report, like we're working on that. I want you and us to think of COVID as one of multiple respiratory viruses that we track, that may impact at different points, that have different mitigations, have vaccines, have masks if you're sick. You might think about distancing, right? And so we are very much working to make sure that data remains central and that you are able to see what that looks like here in Chicago. Okay, one more for you and then one more for me. Jasmine Hernandez on Facebook says, hello, how long do nurses follow families through the Family Connects after that 3-week visit? When might families exit the program? What supports might be in place post Family Connects? A good question from Jasmine.
Yeah, so the Family Connects program is really intended to be a brief intervention.
That's right.
So most of the time for Family Connects, it's 1 and in some cases maybe 2 visits with that Family Connects nurse. Now, if the family has a need for a longer-term home visiting or longer-term home visiting programs, which there are others and there are several, then the nurse will actually connect that family with the longer-term home visiting program that will follow that family longer. But Family Connects itself is typically 1 to 2 visits, depending on the situation.
Yeah, and just to add, when you're thinking about a universal program like this that ideally is offered to everybody, you want to have some standardization. You want to really be doing some screenings. The reason it's called Family Connects is it's also, are there older kids in the home who might want to be connected to early childhood education? Like it's about sort of that whole family. And then the Connects is really saying we can get you to connected to whatever you need and follow up to make sure that that is happening. But that was the gap that we were often seeing, that there were families who were needing longer term services and frankly we're not getting connected to them. And so this is really at a medically vulnerable time. If the mom's got high blood pressure and we don't know about that, we want to make sure that mom is getting in to see her doctor sooner rather than later. If the baby's not feeding well or having issues, we want to make sure that baby's getting in well on the health side. But more important, I think, frankly, is in the kind of in the other ways in which we support families. So good question. All right, and finally, I will just take a last question here. Karen Nathan Sussman from Facebook, and there were a number of questions along this line. So first, she just says, Dr. Already, in a country where too many people think this pandemic is over, your guidance and Ask Dr. Already weekly COVID talks have been helpful. Thank you. And she says, I hope your position under the new mayor would be secure, you're needed. Can you share an update about the security of your position? So Karen and others who have been asking this, I haven't even had an opportunity to meet with the new mayor yet, or the new mayor's team. I am looking forward to that. I certainly am very hopeful to be able to remain on in this role. Public health is what I do, and I will be doing public health, if not in Chicago, I will be doing public health somewhere else, because that is what I do. But I really, really am committed to this city at this point, and frankly to this health department if I'm able to. It's in all the areas. Today we talked about maternal child health, but you've heard what we're doing in behavioral health. You've heard what we're doing in some of the sexually transmitted infections and HIV. You've heard a lot about what we're doing to grow our communicable disease and infectious disease work, really think about vulnerable populations, whether that's folks experiencing homelessness, whether that's folks who are incarcerated, et cetera, et cetera. It's been a really hard 4 years, of course, for everybody, and especially for, once COVID hit, it's been a really hard time at the health department. But it's also been a time, I think, for CDPH where we have, in a lot of ways, come together around how do we use data to think about working on health inequities in Chicago. It's something we'd been interested in before, but during COVID, and you were part of this, making a lot of decisions about how do you prioritize resources, how do you track outcomes to see if you're doing something differently in a community. Are you seeing those data-driven outcomes? I'm all about data for action, and I think in a whole host of areas, it's just been a good time for the health department, and I love my team. So I'm hopeful that I will get to stay on. Obviously, it is the new mayor's decision, and I will respect that. But I don't have an update, and I won't have an update until we've had an opportunity to meet. And so I'm looking forward to that, and then we will share. So on that note, I want to thank again Dr. Candace Robinson, Medical Director at CDPH over our Maternal, Infant, Child, and Adolescent Health Bureau. We will not be on next week. There's actually a maternal child breakfast event thing that I need to go to. But we will be doing another Facebook Live prior to the public health emergency ending and really reviewing again some of the content and some of the details around that. So watch your social media for the update of when that will be. Any last words or anything you didn't get a chance to fit in there? Remind people of the website again, too.
Yeah, remind everybody of the website. Go to oneshyfam.org and to find out all about MICA, our programs, and maternal child health, and parent and family resources.
And thank you for your ongoing interest, really good questions about public health. For as long as this forum is helpful to all of you, we intend to continue it. So thanks again, and we'll see you not next week, but we'll be back before the public health emergency ends. Thanks again.
Bye.